pathologist, and I recently moved from UCSF to Memorial Sloan Kettering. So a lot of the work that I'll be talking about today was done and started at UCSF, but that I have the opportunity now to continue as attending at MSK. I'm a pathologist, so I'll really be talking about kind of ideas that guide me, and also, what does global pathology even mean? Because it's a, pathologists traditionally haven't really been thought of as big players in the global health scene. So I think that's definitely changing. Okay, so I do receive some research funding from Cepheid, and I'll be talking about some of the work that I've been doing with them today. And the outline for today's talk, I'll just be talking about how I got started in global health and some of my own personal experiences. And then also get into how breast cancer is diagnosed in Tanzania and some of the limitations in pathology, and just an overview of a few of the projects that I've been involved in over the last few years. So what is global pathology? I don't think there's a good definition, and there's definitely a lot of different approaches. There's definitely people who just work in capacity building programs only. There's people who work with work with academic partnerships. That's kind of where I fall in. And I also kind of fall into the camp where I do research, but I really do very practical research that really identifies how do you build capacity in a lower research setting. And then there's just another group of people who do primarily research, who look at pathophysiology, and also kind of do more translational research using lower middle income country samples. So when I first started medical school, I first initially got into the global health field really through health literacy and immigrant health. I was really passionate about working with indigent populations and also immigrant populations and trying to increase their access to healthcare. In residency, for some reason, I decided to go into pathology. Even though in medical school, I was pretty sure I was going to go into emergency medicine up until the last 2 or 3 months of my third year. And when I started residency in pathology, basically there were no mentors for me. There weren't a lot of pathologists who, 10 years ago, who were doing global pathology work. And I didn't really have a model for what that looked like. That really changed during a transformative year when I was a fellow at the CDC, and I was a fellow in infectious disease pathology. And there I really saw the intersection between what a pathologist does and also how we interact with epidemiologists to identify different outbreaks. Pathology and lab medicine have been incredibly important now during the current COVID-19 pandemic. And I also learned how important pathology is in surveillance as well of different infectious diseases, as well as cancers. I also had a really great opportunity to act as an infection control field officer during the Ebola outbreak that year. It was 2014 to 15 when I was at the CDC. So I got a chance to go to Sierra Leone and help with some of those efforts as well. Then I decided to do a postdoc with Charles Chu and really worked with advanced molecular diagnostics. It's a little bit different from what I'm going to talk about today, but a lot of these ideas in developing really cutting edge novel assays and as well as adapting assays are things that I apply and that I keep in mind all the time. And then as attending, I finally got incorporated and started becoming an active member with the UCSF Global Cancer Program. And there I started working on breast cancer in lower and middle income countries. So that's really what I'm going to be focusing on for my talk today. So I don't think I necessarily have it figured out. This is kind of just the way, just a talk that goes over kind of my own approach to global pathology. Of course, there are many different ways to approach this. I really take the mission statement of the Global Cancer Program to heart, and it really focuses on 3 pillars: innovative research, education, and collaboration. And we use all of these three pillars to address different gaps in cancer care. And aside from just the mission statement in itself, we have quite a few core values that I also kind of think really ring true, and also are good ideas when you do get involved in global health. is, you have to be innovative. It doesn't hurt to collaborate with industry. You have to be flexible, adaptable, but really you have to find really good partners and also do research that's very impactful and that's locally responsive and meaningful. So for my own projects that I've been involved in, they've all really been locally led. I kind of see myself as the fixer. I kind of try to get things done. But really the vision has been my LMIC collaborators. And so they've been really incredible to work with. And here you can see this is a photo from a multidisciplinary meeting where we had multiple leaders from in global health from different institutions in the US, as well as Tanzania. And here we were talking about, how do we create a robust cancer training program at Muhimbili University in Tanzania. So in terms of introducing interventions, basically these are the 4 phases that I kind of imagine in my mind. First, you do a needs assessment. Then you take your data and you do a gap analysis. So what's missing? Then there's the planning phase. So really there's 3 planning phases, but the planning phase is really when you start to put pen to paper. And in the planning phase, I really use implementation science frameworks. And I'll just really briefly go over what that is. But essentially it's a fairly new field that's multidisciplinary, that is trying to, in a really rigorous way, close the evidence to practice gap. And then finally, after all this planning, then you can try and pilot and execute an intervention. So these are kind of the phases that I kind of adhere to whenever I think about doing something or kind of starting a project with someone. So moving on to breast cancer on the global, in kind of global breast cancer. So as many of us know, breast cancer is the most common malignancy worldwide, and it's also the leading cause of cancer death in women. Breast cancer incidence is increasing in low and middle income countries for a variety of reasons, because of lifestyle, because of diet, exposures, etc., lower parity. And unfortunately, although most of the breast cancers are diagnosed in high-income countries, the majority of breast cancer deaths worldwide are actually in developing countries. So they have a disproportionate burden of death related to breast cancer. And part of this is because breast cancers and LMICs are often diagnosed at very advanced stages when treatments are less effective and survival is very poor. So here you can see here. So in North America, the 5-year survival rate is over 80% for breast cancer, while as in sub-Saharan Africa, the 5-year survival rate is less than 50%. And part of that is that cancer care requires so many moving parts. It's a really complex ecosystem. So you have, a woman has to be able to identify breast symptoms, or maybe her primary care physician needs to be able to identify them. They need to have access to screening. And then after a mass is detected, they need adequate diagnosis, both radiologically as well as for pathology. They need adequate clinical follow-up. And then they need appropriate, available, and accessible care as well. So surgery, chemotherapy, radiation therapy, and if needed, palliative therapy as well. So as you imagine, if any one of these components breaks down, it causes a delay. And if there's enough of these delays, then unfortunately it affects outcome and survival. And so I just want to mention that on March 8th, the WHO announced their global breast cancer care, the Global Breast Cancer Initiative. And so this is now a priority for the WHO. So they've announced that they're going to launch programs that really focus on these 3 pillars: health, promotion, and early detection, timely breast cancer diagnosis, and then comprehensive breast care management. And so I have the opportunity to work on some of their demonstration projects and really focusing on timely breast cancer diagnosis. But they haven't been launched yet, so I'm not going to get into it. So as I mentioned, So because of these complex moving parts, here in an ideal system, a woman is able to enter, to get a screen detected mass, they're able to get a diagnostic workup radiologically as well as through pathology, they're able to get treatment and improved outcomes. But even if there's a breakdown at any single one of these parts, for example, so even if there are treatments available, if there's a delay in diagnosis, then unfortunately, they're not going to be able to access downstream care because an oncologist is not going to treat a breast cancer patient. You're not going to give them chemotherapy if they don't have a diagnosis of breast cancer. So there are a lot of challenges in pathology in lower and middle income countries. So the main problem is that there's a severe shortage of pathologists. So in Tanzania, for example, there's about 30 pathologists for a country of about 60 million people. In contrast, at MSK, where I work, there's more than 100 pathologists on staff. So here you can really see how the disparity is quite obvious. There's training gaps, so there's a lack of training programs in LMICs. It's also not necessarily an attractive field, even in the US. I know it's not seen as a sexy subspecialty. That's okay, but it's an incredibly essential and important subspecialty, especially in cancer care. There's also limited or no subspecialty training available. And if pathologists do want to get subspecialty training, they often have to travel quite far to high income countries to receive this training. There's a lot of barriers to accessing pathology care and services. They tend to be concentrated at national referral centers or select zonal centers. So often a woman, will get referred from their clinic, from a primary care clinic, but then have to wait several months as they're referred through each step of their healthcare system. And then reagents and equipment are costly, so you can't necessarily do pathology just anywhere, just because it's so resource intensive. There's also a lack of screening programs for breast cancer in particular. And there's a very limited screening outcome data in LMICs from mammography, whereas mammography has been incredible and transformative in high income countries. It's seen in some studies to be not as cost effective. And there's only now studies coming out on how effective CBE is in downstaging women, as well as whether it actually affects survival and outcomes or not. What also people don't realize is that if you introduce a screening program, is that there is going to be increased demand for every following service. So there's going to be increased demand for radiology services, pathology services, surgeons, oncologists, nursing, et cetera. So unfortunately, sometimes people introduce screening and they don't realize the burden on the system that's going to be placed, and that even if you detect a mass, a woman is not necessarily going to be able to access care. Okay, so this is just a graphical image of just the clear shortage of pathologists in sub-Saharan Africa. Here you can see Tanzania, at least in the range of sub-Saharan Africa, is somewhere in the middle. So South Africa is doing quite better, a lot better than the majority of sub-Saharan Africa, but there clearly is, there's just not enough. So I mentioned implementation science earlier. So really, I see it as the field that allows us to systematically close the evidence and practice gap. Implementation science really arose because studies in the US were showing that about half of patients in the US do not receive recommended medical care, despite there being good evidence. And then also 30% of medical spending is on unnecessary medical care. So do you really need to get that CDC every day? Do you really need to get that CT? So it's a little bit unclear what these numbers are in different LMICs, but even in the US, it's clear that people are not necessarily practicing evidence-based medicine all the time. And implementation science uses different models, frameworks, and theories. So for example, you would use some variety of process models to help you kind of break down and describe how you would translate research into practice. So you know brushing your teeth is good for you. How are you going to get everyone to reliably do it twice a day for 2 minutes every single day? And then they also use a lot of determinant frameworks, classical theories, implementation theories, which are a little bit more applied to really understand the different external and internal factors that influence outcomes and how you might want to implement something. And then also evaluation frameworks. A popular one, for example, is RE-AIM. There's a lot of acronyms. I'm not going to go over them, but essentially RE-AIM is like basically something that breaks down each and every component, so it allows you to systematically evaluate a program that you've introduced. Another thing that I kind of keep in the back of my mind when I do my research and when I think about working with someone to implement some new kind of intervention are these four concepts. So feasibility, acceptability and uptake, fidelity and sustainability. And so in terms of feasibility, I think about the extent to which an intervention can be successfully carried out in a specific LMIC setting. So if you're going to kind of transport an intervention to a slightly different setting, you know, what are you going to adapt, but what's absolutely essential and what do you have to keep? What's the bare minimum you have to have in terms of resources and what's optional? So I think about resource stratification a lot. You also have to think about, is it fiscally possible, technologically feasible, socioculturally appropriate, administratively, how about ethically? And then in terms of acceptability and uptake, this requires a lot of local stakeholder input. And from the perspective of the stakeholders, is this intervention acceptable? And also stakeholders include physicians, administrators, patients, among others. Fidelity, you know, is the intervention going to be delivered as intended? You'd be surprised that when people introduce interventions, it doesn't always come out as planned. And I've seen some other projects go awry because of this. And then sustainability. Is this intervention actually going to be integrated? And then is it actually maintainable within this LMIC after the project is done? So in that situation, I think having stakeholder buy-in, but also Ministry of Health buy-in is also incredibly important. And if you're lucky, you know, larger organizations like WHO. And then I just want to emphasize the importance of a multidisciplinary approach. And that's why personally I choose to be incorporated and an active participant in a larger program like the UCSF Global Cancer Program, where I'm constantly working with other radiologists, oncologists, surgeons, and radiation oncologists, both in the LMIC site as well as in the US. I think you know, no subspecialty can really go at it alone. So multidisciplinary approach is absolutely essential. And for example, I've known a few radiologists who introduced programs where they just hugely increase capacity for cores, for biopsies, but they didn't think about whether the pathologist would handle or not. So now we're kind of working with radiology as well as pathology to really see what both groups need, and as well as talking to oncologists and surgeons what they need to treat patients further down the line. Okay, so this is our team in Tanzania, and just kind of re-emphasizing the multidisciplinary approach. It's composed of pathologists, epidemiologists, laboratory scientists, and those are a pathologist's best friend. They are absolutely essential. Oncologists, surgeons, and of course, research coordinators as well. This is a map of the major hospitals in Tanzania that provide cancer care as well as have pathology services in Tanzania. So they're basically spread out around the 4 quadrants of Tanzania. And primarily, I work with Muhimbili National Hospital, but the goal is to kind of expand our work to the other 4 centers. And just to mention, Ocean Road Cancer Institute is a cancer center only. So it's the only comprehensive care center in Tanzania, and they only do treatment. Just so a little bit more about the how the Tanzanian healthcare structure is arranged. So having all this background in your mind is really important. So it's a hierarchical one. So women generally access care through the clinics or the district hospitals initially, and they have to be slowly referred through each level. And so only really finally in the zonal hospitals or national hospitals where they're able to get a little bit of pathology care, pathology services, where they're even able to get a minimum of cancer care. So most of the cancer care and radiological services, pathology services happen at the national hospital level. And one thing to note is that when you're thinking about implementing some sort of intervention, it's a balance between quality and access. So as you make it more accessible, it's great, you're able to reach more people, but you have less control over the quality. So you really have to think about at what level are you going to introduce your intervention. I think this is really important for higher resource interventions or subspecialties. So whereas an educational intervention, you can probably do it at every single level, but for something like pathology, really, you have to think about what level are you going to reach the most people, but also still maintain quality. Here's just a chart of the human resources that are available in cancer care in Tanzania. There's not a lot of oncologists, not a lot of radiologists or pathologists. And also, I just want to mention that oncologists, they're both are responsible for chemotherapy and radiotherapy. So there's no radiation oncology subspecialty, actually. The oncologists do it all. And just going into more detail about Muhimbili National Hospital, where I primarily work in. It's one of the 3 national referral hospitals, and it's huge. It has 1,500 hospital beds, and they provide cancer care, but also care for any other disease. The majority of suspected cancer cases in Tanzania are referred to their central pathology laboratory. They're one of 2 hospitals that provide immunohistochemistry, so stains. But even then, despite being the sister organization to Ocean Road Cancer Institute, the Comprehensive Care Center, they only see 10,000 surgical specimens and 7,000 cytology specimens. They do have a well-established daily FNA clinic, and they see over 50 patients every week. And just going over breast cancer and pathology, the pathology of breast cancer in Tanzania a little bit more, there haven't been a lot of articles. There's only been 4 or 5 published, and most of them have been pretty small. So we actually don't know a lot about breast cancer in Tanzania. But what all of these studies have generally found is that regardless of the hospital, they found that the majority of women present at advanced stage. So at Muhimbili National Hospital, you see 84% with stage 3 or above breast cancer. At Ocean Road Cancer Institute, which basically is kind of like the hospital at the end of the line, they're seeing people with even with more advanced stage. And then Buganda, which is right by Lake Victoria, in the Northwest, they see about 63% of patients presenting with stage 3 or 4 cancer. So there's a lot of challenges, not just in routine pathology, but in particular hormone receptor testing. So as we all know, hormone receptor testing is incredibly essential and important in breast cancer diagnosis and treatment and prognosis. However, hormone receptor testing is unavailable at most hospitals in Tanzania. So you're either looking at private practices, private laboratories that are prohibitively expensive, or you access one of 2 public hospitals that have immunohistochemistry. So in one of our pilot studies, we found that out of the women who are presenting to FNA clinic with a breast mass and are diagnosed with breast cancer, only 28% of these people are receiving hormone receptor testing in the end. The median turnaround time for people who are before people who are receiving testing is about 2 months long. And I want to make a note that in Tanzania, or actually at Muhimbili, the majority of women are diagnosed initially by FNA. So unlike in the US where you might do a core biopsies are just too expensive. And actually open biopsies are less expensive in Tanzania than a core biopsy. So the majority of women are initially diagnosed with the FNA, and then you can't do hormone receptor testing on an FNA. And then the woman has to wait after her diagnosis to get scheduled for surgery and then get an open biopsy or mastectomy, and then wait for their immunohistochemistry to be done on that surgical specimen. So as you can imagine, there's actually quite a bit of delay. And then there's also a shortage of highly trained technical staff and pathologists, so immunohistochemistry is not as reliable. Sometimes, actually, what people don't realize is that it's a really finicky test where it's routine in the US, but there's a lot that goes on in the background in terms of quality controls and validation. Equipment and reagents for immunohistochemistry is very expensive. And because there's often middlemen in sub-Saharan Africa, immunohistochemistry reagents can be more expensive in Africa than it is in the US. And also, before the specimen even gets to the pathologist, sometimes you just don't know what happens to it. The handling is very variable. And also technical procedures. Sometimes I've been to places where they don't necessarily have SOPs, while other places do, but you're not really sure if you can rely on the immunohistochemistry or not. And so so I started brainstorming with my LMIC collaborators, and so we really identified this hormone receptor testing and breast cancer diagnosis as a major gap, just because there's so many women with breast cancer in Tanzania. And if we could just help expedite the diagnosis, at least it would help to close the gap a little bit. So here's the conventional paradigm where a woman gets an open biopsy or mastectomy, and it takes weeks to months to get a final diagnosis and her biomarker results. So ERPR HER2. And here we kind of brainstormed, and basically we proposed an intervention where we could reduce this in a single day. And the components of the intervention were a fine needle aspiration biopsy, which works perfectly well in a setting where the majority of women are coming in with large masses. I don't necessarily recommend it for DCI, it's not supposed to diagnose DCIS or a woman who gets calcifications identified on her screening mammography. This is really appropriate for a setting where a woman presents with a mass. And then we combine it with rapid on-site evaluation. So this allows us to immediately diagnose and at least immediately triage patients into whether they have a benign mass, an indeterminate mass, or a malignant mass. And then something called the Strat4, which is produced by Cepheid. So it's a gene expert cartridge, and I'll talk a little bit more about that. But it's an automated PCR that lets us test for ERPR HER2 and Ki67 basically in a couple hours. So essentially, we were trying to compress weeks to months down to a single day for our pilot program. And so instead of doing everything at once, what we thought would be a little bit more palatable and a little bit more feasible is if we broke down each of these components. So FNA, rows, and then Strat4. So can we do this with high fidelity, high quality in a sustainable way in Tanzania? So what we first started out with was a 3-day FNA biopsy training workshop. Are these workshops even effective? So I think for decades, there's been a lot of pathologists who have been, holding FNA biopsy workshops, throughout the world. And really, I was surprised that there was never any study showing whether these workshops were effective or not. And this was really low-hanging fruit. But I mean, if you're going to spend the time, spend the money flying people out from the US, it'd probably be helpful to know whether this is effective or not. So Edda Hula, who's been my collaborator through all of this, you can kind of see the back of her head here. We decided to invite radiologists and pathologists from all over Tanzania for a 3-day workshop. And here you can see we are teaching an ultrasound, radiology resident here how to do an ultrasound guided FNA. And we use chicken breasts stuffed with little olives and other beans and other goodies for them to target here. And we published our experience here in the Journal of Global Oncology. And what we found is that indeed, these workshops do work. And so for every component or important technical skill involved in ultrasound guided FNA biopsies, you could see that there was statistically significant improvement. We're currently working on a study that is evaluating whether these skills are sustained after a workshop like this, which is of course very important. We then started looking at rapid on-site evaluation. So I started teaching for Tanzanian pathologists how to do this. So essentially you do a really quick stain and you try to decide immediately whether it's cancer or not. And so for the most part, at least in our kind of preliminary data, we've shown that there's a high rate of accuracy for rapid on-site evaluation among the Tanzanian pathologists who are trained. And here you can see Asteria Kamambo, who probably has the most experience with this. She's at a breast cancer screening program. And here you can see she's looking at a slide. And this, for those of you who are pathologists, this is obviously malignant. But here you can see cells that have been stained with toluidine blue. And you can see really large, kind of disorganized cells with large nuclei, very prominent nucleoli, vesicular chromatin. So this is clearly an adenocarcinoma. And we published this study, our experience of using ROSE, actually applying, not just teaching, but applying ROSE to a breast cancer screening program and applying ROSE to really immediately triage patients. What's important about immediate triage is that a complaint that people have had about clinical breast exam is that there's such a high false positive rate. So essentially you detect a mass, but most of those masses are going to be benign. And so you end up overwhelming the downstream healthcare system with women with benign masses, as opposed to just really focusing on the women who need cancer care. And so in our study, we had about 200 women who presented to a breast cancer screening program at a trade fair. So Muhimbili National Hospital, every year they have a presence at this trade fair. They usually do hypertension, diabetes screening, as well as prostate cancer screening, where they look for elevated PSA. And this year they decided to introduce breast cancer screening. So a team of nurses, oncologists, pathologists, medical students, and research coordinators were involved in the CBE and actually the entire workflow. So most of the women were found to have normal breast exam. A few, 19 women were found to have abnormal clinical breast exams. And we excluded the women who had breast pain or discharge. They were referred for additional workup or follow-up. So out of the women with palpable breast masses, there were 15. Two of them were deemed too small by the pathologist to biopsy at the site, at the screening site. And so there were 13 cases that were actually biopsied and ROSE was applied. So the majority of the cases were identified as benign, and 4 were considered suspicious for malignancy, but I think a couple of them were overinterpretation, but 1 was confirmed malignant. So here you can see how ROSE, at least on a small scale in this feasibility study, can be used to help immediately triage women. And we actually found that all of these women ended up actually following up at Muhimbili for care, as opposed to getting lost to follow-up. Another study that we looked at was basically, can we use traditional methods like immunohistochemistry but apply them to cytology specimens. So cell blocks are not new to pathologists, but they were new at Muhimbili. And actually in low resource settings, it's incredibly difficult to do immunohistochemistry on cell blocks. And we felt that if we could introduce immunohistochemistry on cell blocks, we could help expedite care for not just breast cancer, but a number of diseases, because the first diagnostic procedure that many people receive in Tanzania is an FNA. So here we evaluated the performance of estrogen receptor immunohistochemistry on cell blocks from breast cancer patients. So what we found essentially was that the immunohistochemistry at Muhimbili was the same as the immunohistochemistry performed at UCSF. And then we also correlated with the mastectomy specimens. It was also very high correlation. One thing I do want to note is that in our study, we did collect clinical pathologic characteristics. And so in terms of clinical tumor size, I just want to reiterate just how big these masses are, where the majority of women have tumor sizes more than 2%, but actually more than half had tumors that were greater than 5 centimeters. And then over half of the women had palpable axillary lymphadenopathy, which entirely correlated with metastasis. So essentially any woman who presented with axillary lymphadenopathy, we did a biopsy in her lymph node, and in all these patients, we confirmed that there was regional metastasis. And here you can see some images of the immunohistochemistry comparing, this is a sample from Muhimbili, and this is a sample from UCSF, so very similar. Now, moving on to STRAT4. So we found that FNA and ROSE were feasible in Tanzania and teachable. So we're in the process of wrapping up our pilot study, looking at the performance of STRAT4 on FNA in Tanzania. So STRAT4 is, as I mentioned, an automated multiplex PCR. It looks at mRNA and is able to give you ERPR, HER2, and Ki67 results in less than 2 hours. So from sample to answer. It's really nice because it's standardized and it just takes less effort to train someone. And this is a study using formalin-fixed tissues, so core biopsies, open biopsies, mastectomy specimens. And you can see the ER and HER2 perform pretty well. PR and Ki67, not quite as well, but ER and HER2 are very important for treatment. So there is still utility in the STRAT4. So in terms of the workflow for our own study, we recruited women from the FNA clinic who, these were women who were presenting to clinic anyway for a diagnosis of their breast mass. So an routine clinical FNA biopsy was done. And then if it was determined to be malignant by rapid on-site evaluation, additional material was collected and the strat form was performed. And we also collected for cell block so that we had that immunohistochemistry correlate. So samples were collected for immunohistochemistry, and that was done at UCSF. We also correlated with the immunohistochemistry done at MNH on the mastectomy specimens when available. And then we also collected data from a patient's chart and also did some clinical follow-up to collect data on treatment as well as vital status. So this is just a picture of the clinic. This is again Asteria doing a rapid onset evaluation, and these are just some slides being prepared. And for those of you who haven't seen an FNA done before, here is a pathologist pinning, or actually anyone, doesn't have to be a pathologist. Here's a practitioner pinning down a mass, and here you take a really skinny needle and you just move it back and forth, and just through capillary action, you collect tissue in the hub of the needle. I do have to say FNAs are very operator dependent, so you do need to have someone who's actually well trained in FNAs. It seems easy, but it's not quite as simple to really get an excellent sample. Here we have some cell block processing. I would say this is not a universal method of creating cell blocks. Of course, having the requirement of having a centrifuge makes things a little bit more resource intensive. We are lucky enough to have one at MUHAS. And really the idea is to, for breast cancers, to get rid of the cell block and replace it with Strat4. And here we have our research coordinator, one of the research coordinators from MUHAS, Dr. Sama Filippo. He's making some of our cell blocks here. And so what are some of our next steps? So our pilot study shows really promising data. So the IHC and FNA correlate very highly. So what we're doing now is we're getting ready to actually introduce this into Muhimbili University and possibly other sites in Tanzania. So we are currently about to kick off a qualitative study to evaluate barriers and facilitators to breast cancer diagnosis, hormone receptor testing, and also implementation of the gene expert. And this is being led by Dr. Kimambo, who's pictured here. She's also a current, and this project is actually funded by a Global Fellowship, which is a Fogarty type of NIH Fogarty Fellowship. We also have another project that's ongoing that uses a pre-existing data. And here, Dr. Lauren Eiler is going to lead this project where she's going to use mathematical modeling techniques to evaluate the cost of implementation, scale up, as well as potential clinical impact. The next step, which is going to be co-led by Dr. Etta Vuwula, is to actually pilot this intervention to increase hormone receptor testing and really see if there's any clinical impact on patients. And then another project that's not directly related to Gene Expert, but is related to quality control in general, is we are also in the process of planning and launching a quality improvement project that leverages whole slide imaging, since Muhimbili now has a whole slide imager. So aside from all this research, I'm also very involved in just traditional pathology capacity building efforts and education and training. So one thing is that that we've partnered with ASCP, the American Society of Clinical Pathology, to use their whole slide images, to use the whole slide imagers that were donated by them to MUHAS to provide telepathology in Tanzania. So we have a cohort of about 50 US pathologists. Every subspecialty is represented, and they just look at cases, challenging cases that Tanzanian pathologists need a little bit more help on. I'm also involved in a lot of QI and QA training, ultrasound guided FNA didactics, although this has now really been passed on to other Tanzanian pathologists since they're so competent and actually they have expertise in this area. I do resident lectures when I'm in Tanzania. I provide mentorship and dissertations and really trying to get, so every Tanzanian pathology resident is required to write a dissertation and do a research project. And so I've been helping them not only brainstorm about their projects, but I've been helping a couple of them try to publish their dissertations as well, and really get it out there in a peer-reviewed journal, since so many of these end up just staying very local and never get published in a peer-reviewed journal. The UCSF Global Cancer Program was awarded a D43 training grant. I'm one of the many mentors represented in this grant. And the goal of this grant is to really train a cohort of independent cancer researchers in Tanzania. And then there's also GloCal / NIH Fogarty Fellowships. So we've had 2 Tanzanians, one trainee from UCSF, and possibly another Tanzanian who's currently on the wait list for this, but so 3 who successfully got the GloCal Fellowship and 1 person who's been waitlisted. And then also something that I helped set up for pathology residents is actually, this is essentially an exchange program where we had MUHAS residents going to UCSF and UCSF residents going to MUHAS. This has clearly been paused since the pandemic, but despite leaving UCSF, I made sure that it was sustainable. And once the pandemic is over, then people, UCSF residents and MUHAS residents can continue the exchange program. It is GME approved, so it does count as a elective, a sanctioned elective for UCSF residents. So in conclusion, pathology is essential to cancer care in all settings, and it's really important to establish meaningful long-term partnerships. And essentially, everything I've done is basically because of the partnerships that my mentors have built. So, the partnership at MUHAS is probably 20 years old. So I really benefited from that long-term relationship. Interventions need to be locally driven and responsive, and really need to be built to be sustainable from the get-go. And you really have to consider the entire health system. And it's hard sometimes, especially when you work in a single subspecialty in the US, you don't really think about the other components, but it's really important to think about how your intervention will interact with the cancer care continuum and ecosystem. So there's a lot of people to acknowledge. I think teams from MUHAS, UCSF, as well as Cepheid. And here are my funding sources. And thank you again for inviting me. And I'd be happy to take any questions.
Thank you so much, Dr. Yang. It was incredibly interesting, and I learned a lot, certainly. If there are any questions, feel free to raise your hand and I will unmute you or put the questions into the chat box and I can read those off. If that's okay, I will start with a couple of my questions. You mentioned that the women present with advanced stage, which I suspect most likely stems from the fact that there is a lack of the early detection system in place, such as screening. I was wondering, on the other hand, let's say we increase the screening by bringing 150 mammogram machines to the country. Do you have a concern that such approach may perhaps overload the system, that there just aren't enough people to process all the radiologic imaging and perhaps do all the FNAs? Where do you see like the right balance in bringing the good stuff but not causing unexpected trouble within the system?
I think that's why it's important that it needs to be a Ministry of Health effort. It can't be one researcher or even one academic institution doing this. It really needs to be locally driven and at a very high governmental level. I think this is why it's really important for the WHO to really announce this as a priority. So it can be a problem if you introduce a lot of mammography equipment and then just kind of first of all, don't train people, right? There might not be enough radiologists and there might not be enough technicians to do the mammograms. So it's not even just a downstream, it's like the immediate effect as well. So it really just has to be this multi-pronged approach. And I forgot to mention that for this talk, I really focused on what I was doing, but as part of the Global Cancer Program, I'm not talking about like the dozen other projects that people are working on at both the screening side, as well as kind of the treatment end. So there's oncologists who are working on closing the gap for treatment, and nurses who are trying to close the gap for screening as well, and kind of primary care providers as well. So I don't really have a good explanation, but you need a lot of money, you need a lot of committed people and governments.
And you need the support from the local government. Exactly. I feel like that sometimes that aspect is horribly underestimated and overlooked, that really, it's really difficult to have anything sustainable without the local government support. So I'm actually really appreciative of your answer. And I was curious, you mentioned that very little is known about like the molecular characteristics of the breast cancer in Tanzanian women. I was curious, how is the age distribution there? Is it similar to the US or is it different?
So it seems like they are slightly younger, kind of more in the 40s. There's a lot of, so I just want to say there's a lot of information about West African breast cancers, and there's just less on East African, and it's a completely different population. So in terms of genetics, but in terms of presentation, they are a little bit younger.
So I'm guessing that overall prognostically, inherently, this must be worse prognosis as well because of the younger age of presentation. Is anything known in detail about the genetics at all?
I personally haven't come upon a paper. So I know there's an effort right now, but I actually haven't come upon a paper that looks at East African populations. Interestingly, there's a paper from Kenya that looks at triple negatives, and they actually say triple negatives are not enriched in Kenya. And that some of the enrichment in other places that have published in East Africa is maybe due to bad fixation. So it's kind of like up in the air. So even that, just simple, what's the distribution of ER/PR HER2 status is unknown.
You mentioned the telepathology collaboration, which I think is incredibly interesting, but I'm curious, under my assumption, the US trained pathologist time is actually quite expensive. So I wonder, how is, telepathology, what's the role in the broader global context, I guess?
So right now, ASCP has been really effective in recruiting volunteers. So everyone volunteers, and you recruit enough people where, so this is not meant to replace pathologists in Tanzania. It's supposed to augment. And so ASCP is not creating telepathology services for places that don't have pathologists, because as you mentioned, it'd just be impossible. And right now it's non-reimbursable. So pathology, we make sure we recruit enough pathologists where they do maybe at most 1 case a week, and they're willing to volunteer that time. I think in the end, it might not be hugely sustainable, but it's a bridge. It's telepathology is really a bridge. It's not supposed to replace something or be in perpetuity.
Yeah, that makes total sense. And it kind of brings me to the point that you raised, that pathology as a specialty isn't necessarily among the most attractive ones, either in the US or in Tanzania. What do you think can be done to make it more attractive?
I think physicians overall in somewhere like Tanzania are underpaid. It's hard. I think there's an association with like autopsies. That's not like, I haven't done an autopsy in like 6-7 years since residency. Like I probably would never want to do actually I never want to do autopsy again. It's hard. I I don't really know. I think people just need to change the conception. For example, like pathologists can see patients if they do biopsies. I think it's really important. I think there's, it's hard to, it's really, I don't know. I don't really have a good answer. Even in the US, the numbers are dropping. So gotta figure out a way to recruit more people.
Do you think, aside the kind of mispresentation where people do, I think, associate pathology primarily with the autopsies, is there any consideration of perhaps like an alternative educational route to that? Do you really need 4 years of medical school to be a good pathologist? Maybe you do, I have no idea. But sometimes I wonder, if for those, high need, but, lower interest, perhaps areas, whether like a PhD or MS routes would be feasible at all.
Yeah, I mean, that would be a good consideration. I'd have to think about the competencies. I feel like having a strong medical background is essential. But the question is, do you need 4 years? For example, like I think the surgery rotations were really important, and so were my radiology rotations, but I don't know if I needed my peds rotation. So, maybe psych. I mean, I could have skipped psych. I think peds was important, but psych.
And I was really intrigued by the workshop that you showed, the chicken breast with the olives. I thought it was really creative.
I didn't come up with that. That's a honored tradition at UCSF.
It's really conceptually intriguing. And I was wondering, for example, I did my PhD in Britain in the dermatology department. And many, if not most of the dermatologists are actually very skilled at reading their own slides. Because dermatopathology was so hard to come by, they just learned how to do it themselves. And my question was, can you see perhaps like a slide reading or cell block reading workshop as perhaps being a way to augment the access to proper diagnosis in low-income countries?
I think so. I think there's also a role for AI and image recognition using like a cell phone for places that, because it's hard to really highly train someone to do everything, right? They're supposed to be highly trained in ultrasound, in reading slides, like in clinical breast exam, and then everything else they have to do, and then delivering babies. But I think there's a role to having kind of physician extenders be trained in that as well. because it's at least, even at least like cancer or not cancer or indeterminate, just kind of putting it in some sort of like bucket.
The basic boxes. Dr. Allenby, I see you raised your hand, so I will hopefully unmute you. I'm not sure if it worked.
Okay, can you hear me?
I can hear you.
Okay, good. Yeah, Dr. Eng, I'm a pathologist at Ohio State, and I came to the global health through a different route. I actually became involved with a group in Tanzania directly to an GMO or an NGO, non-governmental. And I'm actually involved with a clinic that's in Shinyanga, what you'd put at the bottom of your pyramid, your triangle, a primary healthcare clinic. And but I have been to Bugando, and I have been to KCMC and met with the pathologists there and seen what they do. Because I've been wanting to, I'm actually involved with the clinic in a very general way, just to help them increase their capabilities and just try to help them in their become a larger, more capable facility. But I actually started with pap smears. I'd wanted to really get pap smears going, and that turned into be not very feasible because of the sending the smears off to Bugando, and then they don't even really do them much anymore. The practice was to do a biopsy, well, do like what they used to do in the old days, is do the acetic acid exam on the cervix, and then do a biopsy if it's positive, and go sort of straight to treatment, because you don't know if the people will actually return, what the follow-up will be. Like you say, it takes weeks to months to even get a pathology result back. So I mean, I'm looking at this just very much out on the clinic, where you're in the capital, you're in Dar es Salaam at the big places, and I'm doing this out in the small little clinic, and I can see how hard it is to implement what you're talking about. So, but it's very interesting, in theory. I would love to hear more about, just stay in contact and hear more about what's possible. And if there's any way to be, to look into it at on the clinic level, I'd love to collaborate, but it's very difficult.
Yeah, that's definitely something we've been thinking about. It's just because the need for quality control is so important in pathology. Right. That it would be nice to get down to the clinic level, because so many places have gene experts, so it's not really an issue, but it's really kind of like confirming cancer in the sample. So yeah, it's hard. And I think this workflow that we have works really well in more centralized hospitals. But I've been brainstorming, and I've actually been talking to Dan Milner at ASCP, as well as Ben Anderson from WHO. But how do we actually take this down to the clinic? So, I'm still fairly early in my career, so there's a lot of things I need to learn about. But I've never actually kind of taken something from a more centralized location and kind of dispersed it. But I think about that all the time, and I just don't have that experience.
Yeah, I mean, I'd love to keep in contact and see if there's any possibility of translating it down to the clinic level of being involved with that. I would love to be.
Yeah, we can kind of, I guess, take things offline.
Yeah, I'll get your contact info.
Yep. Nicole can send you my email.
Yeah, great.
I'd be more than happy to provide the connection there. It's exactly 7 o'clock. I'm happy we're on time. I don't see any more questions either in the chat box, and I don't see any more raised hands. So I will express my most sincere thanks to Dr. Eng for this fantastic talk. And we wish her a pleasant evening in New York, and hopefully we'll see you one day again.
Thank you.
Thank you so much, and have a good evening, everybody. Thank you for joining us tonight.